So, have you ever finished a really incredible, maybe slightly, overly indulgent meal?
Oh, absolutely. Like a really thick marbled steak.
Right. Or a heavy cream pasta, or maybe just a classic greasy double cheeseburger.
Yeah, the kind where you need to unbutton your pants afterward.
Exactly. You enjoy it, you sit back, and then a little while later you feel this unexplainable, crampy, deep ache right in your upper right abdomen.
And it's not just there. Sometimes it radiates around your side, right?
Yeah, or even sheeting up into your back right behind your right shoulder blade. And, you probably just write it off as bad indigestion.
Most people do. They just take an antacid and try to sleep it off.
But there is a very good chance that what you are actually feeling is a tiny crystallized stone. I mean, sometimes it's no bigger than a grain of sand, and sometimes it's the size of a golf ball.
Which is terrifying to think about.
It really is, and it's throwing a literal wrench into your entire digestive machinery. So today we are talking about gallstones.
And, it is a condition that affects an enormous portion of the population. We are talking about millions upon millions of people dealing with this at some point in their lives.
It's everywhere.
It is. Yet for something so incredibly common, the actual biology of how these stones form, why they form, and the sheer chaos they can cause inside the human body is completely misunderstood by most people.
Right. It's not just a rock you swallow.
No, not at all. This isn't just some random digestive quirk or a minor annoyance. It's a deeply complex biological process that ties together our diets, our genetics, our immune systems, and get this, even the industrial chemicals in our modern environment.
Which is wild, and understanding that complex biological web is exactly our mission for this deep dive.
We're going in deep today.
We really are. We are going to explore the literal microscopic chemistry of how your body accidentally manufactures these stones.
Accidental alchemy, basically.
Exactly. We're going to break down the environmental and genetic risk factors, and some of these are going to completely upend what you think you know about healthy habits.
Oh, definitely. There are some real surprises in the data.
And we'll demystify the medical detective work, tracing the journey from the moment a stone blocks a duct through the diagnostic imaging all the way to the operating room. We want to equip you with a profound understanding of the machinery operating inside your own abdomen.
And to do that, we're drawing from a remarkably comprehensive clinical review updated recently in the NCBI bookshelf.
Right, the Stat Pearls review.
Yeah, by Jones, Weir, and Marietta. It's an exhaustive look at the clinical reality of gallstones. It pulls together the biochemistry of bile, epidemiological data, surgical guidelines, and long-term outcomes.
So it's basically the ultimate roadmap for this topic.
It really is. It provides us with a perfect foundation to understand both the microscopic origins and the macro-level clinical treatments.
But, before we get to the operating room, or even how these stones trigger that agonizing pain after a cheeseburger, we have to start at the very beginning.
We have to understand the ingredients.
Right. We have to understand what these stones are actually made of. Because, like we said, you don't just magically swallow a stone, your body makes it.
It's a manufacturing defect.
Exactly. And it makes it out of a liquid called bile. So let's unpack this chemical manufacturing process. What exactly is bile, and where does it even come from?
Well, to understand bile, you really have to look at the liver.
Okay.
Your liver is, it's the ultimate chemical manufacturing plant in the human body. It processes nutrients, it detoxifies blood, and synthesizes crucial proteins.
This is busy.
Incredibly busy. But one of its most important jobs, right alongside those, is the continuous production of primary bile acids. And the liver creates these acids using a base material that we hear about all the time, usually in a negative context.
Let me guess. Cholesterol.
You got it. Cholesterol.
We usually think of that as the stuff clogging our arteries, not the base ingredient for digestive juices.
I know, it gets a bad rap.
Yeah.
But cholesterol is a foundational molecule in biology. It builds cell membranes, and it's the precursor for steroid hormones.
So we need it.
We absolutely need it. And in the liver, it undergoes this massive transformation to become bile. But this transformation isn't simple. It requires a highly specific enzymatic process called hydroxylation.
Hydroxylation, meaning it's adding what? Water?
Sort of. The liver essentially attaches oxygen and hydrogen atoms to the cholesterol molecule to change its physical structure. And an absolutely crucial cofactor for this specific reaction is vitamin C.
Wait, vitamin C, like orange juice vitamin C.
The very same.
So vitamin C isn't just for fighting off a cold, it's actively participating in the liver's ability to process and clear cholesterol.
It is essential for it. The liver uses an enzyme, specifically 7-alpha-hydroxylase, if we're being technical, which relies on vitamin C to take that raw cholesterol and convert it into water-soluble primary bile acids.
Oh, okay.
Yeah. Once the liver manufactures these primary bile acids, it secretes them down into the bile ducts, which eventually lead to the intestines. But the chemical journey doesn't stop there.
Where does it go?
Well, once these primary bile acids hit the intestine, the bacteria living in your gut, your intestinal flora, they get a hold of them.
The microbiome steps in.
Exactly. These bacteria possess their own enzymes that strip away certain chemical groups, converting the primary bile acid into secondary bile acids. And eventually, through further processing by the gut and the liver, you get tertiary bile acids.
It sounds like a massive recycling loop. I mean, the liver makes the primary version, dumps it into the gut bacteria modify it, and I assume the body pulls it back in to use again?
That is precisely what happens. It's called the enterohepatic circulation. Entero meaning gut, hepatic meaning liver.
Enterohepatic, got it.
And your body is incredibly efficient at this. About 95% of the bile acids secreted into the intestine are reabsorbed in the final section of the small intestine, which is called the terminal ileum.
95%. That's a huge retention rate.
It is. They're absorbed into the bloodstream, sent right back to the liver, and secreted all over again. Yeah. A single bile acid molecule might complete this circuit several times during a single meal.
Okay, so we have this constantly circulating pool of modified cholesterol acting as bile. But what is its actual job? Why is the body going through all this metabolic effort to pump this stuff into the gut?
It acts as a biological detergent.
A detergent, like laundry soap.
Basically, yeah. The structure of a bile acid is fascinating because it is amphipathic.
Amphipathic, meaning what?
It means it has a split personality. Yeah. One side of the molecule has a hydroxyl group, a glycine or taurine side chain, which is highly hydrophilic.
Hydrophilic. It loves water.
Right, it loves water. The other side of the molecule is a steroid ring structure that is hydrophobic. It fears water, but it loves fats.
Oh, I see. So it can grab onto a piece of fat with one hand and grab onto the watery environment of the gut with the other.
Exactly. When you eat that cheeseburger, the fats in the meat and cheese enter your watery intestines as giant, unabsorbable globules.
Because oil and water don't mix.
Right. Your digestive enzymes, which are dissolved in the water, simply can't penetrate those fat globules, so the bile acids surround the fat globules.
Like a swarm.
Yeah, the fat-loving sides attach to the grease, and the water-loving sides face outward. This breaks the giant fat globule down into millions of tiny microscopic droplets. We call those micelles.
So it's exactly like dish soap breaking up the grease in a dirty frying pan.
It is the exact same chemical principle. Once the fat is broken down into these tiny micelles, your pancreatic enzymes can easily access the fat molecules, break them down, and your intestines can absorb them.
So it's basically unlocking the fat for digestion.
Without bile, you cannot digest or absorb dietary fats, or even fat-soluble vitamins like A, D, E, and K. So bile is an absolute necessity.
Right.
The problem arises not from the bile itself, but from the balance of the ingredients suspended within it.
Which brings us to the stones. If bile is this highly tuned detergent, how does it suddenly turn into a literal rock?
Well, the liquid bile isn't just bile acids. It is a complex mixture of bile acids, phospholipids, and unesterified cholesterol.
Okay, so a lot of ingredients in the soup.
Right. The bile acids and phospholipids work together to keep that cholesterol dissolved in the liquid. But if the liver pumps out too much cholesterol or not enough bile acids, that delicate chemical balance shatters.
The liquid suspension fails.
It reaches a state of supersaturation.
Ah.
The liquid simply cannot hold the amount of cholesterol dissolved within it. So the excess cholesterol has nowhere to go but out of the solution. It precipitates.
It turns solid.
It turns from a dissolved liquid state into microscopic, solid cholesterol crystals.
You know, it is exactly like making raw candy when you're a kid.
That's a great comparison.
Right. You take a pot of hot water and you start stirring in sugar. You dissolve cup after cup of sugar, and eventually you hit a point where the water is completely supersaturated.
It physically cannot absorb one more grain.
Exactly. And if you drop a string into that pot, the excess sugar precipitates out of the water and crystallizes onto the string, building a solid rock of sugar.
That is a perfect analogy. But in the gallbladder, there is no string. Instead, there is mucin.
Mucin, like mucus.
Very similar. The lining of the gallbladder secretes a highly viscous, sticky protein called a mucin glycoprotein matrix.
Okay.
Its normal job is to protect the lining of the gallbladder from the harsh detergent effects of the bile. But when cholesterol supersaturates and those tiny microscopic crystals form, they get trapped in this sticky mucin gel.
Oh man, so it's like a trap.
Yeah. The mucin acts as a nucleating factor, the biological equivalent of your rock candy string. It catches a crystal, holds it in place, and allows more crystals to attach to it.
So you end up with a sticky gel full of tiny, rock-hard crystals.
Clinicians literally refer to this early stage as biliary sludge.
Sludge. That sounds awful.
It is exactly what it sounds like. A thick, granular, highly viscous sludge sitting at the bottom of the organ. And if that sludge isn't forcefully flushed out, those crystals continue to aggregate, growing larger and larger over months and years.
And eventually forming solid macroscopic gallstones.
Exactly.
Now, I want to pause here because the clinical review categorizes these stones, and they are not all the same.
No, they're not.
The process we just described creates one specific type, but there are actually three main categories. And what they are made of tells us a very specific story about what went wrong in the body. Let's go through them. The first, which we just described, are cholesterol stones.
Yes, and these are by far the most prevalent. In Western nations, cholesterol stones account for roughly 75% to 80% of all gallstones.
Wow, so the vast majority.
Yeah. They are typically yellow or green in appearance. And as we discussed, they are the direct result of cholesterol supersaturation. We see these predominantly in individuals with diabetes, obesity, and other forms of metabolic dysfunction where the liver's cholesterol management is altered.
Okay, so that's the overwhelming majority, yellow metabolic stones. But then we have the second type, black stones. And honestly, the name alone sounds much more ominous.
It does sound bad.
If they aren't made of pure cholesterol, what are they?
Black stones are entirely different chemically. They are composed primarily of calcium bilirubinate.
Calcium bilirubinate. Okay, break that down.
To understand where they come from, we have to step away from dietary fats entirely and look at your blood.
Our blood.
Yeah.
Yeah.
Your red blood cells contain a protein called hemoglobin, which carries oxygen. Now, red blood cells have a lifespan of about 120 days, after which they are broken down.
They age out.
Right. And one of the major waste products of breaking down hemoglobin is a yellow pigment called bilirubin.
Ah, the same pigment that causes jaundice if it builds up?
Exactly. Normally, the liver grabs this bilirubin, processes it, and dumps it into the bile to be excreted in your stool. In fact, bilirubin is what gives human stool its normal brown color.
Fun fact of the day.
Right. But if a person has a condition where red blood cells are being destroyed at a massive accelerated rate, a process called hemolysis, the liver gets completely overwhelmed.
It can't keep up with the recycling.
It can't. It dumps massive amounts of unconjugated bilirubin into the bile. This bilirubin binds with the calcium in the bile to form highly insoluble calcium bilirubinate.
And that's solidified.
It polymerizes into incredibly hard jet black stones.
So if a surgeon pulls a black stone out of a patient, it's a huge red flag that the issue isn't their diet, it's actually a blood disorder.
Exactly. You see black stones in patients with sickle cell anemia, hereditary spherocytosis, or even patients with artificial heart valves that mechanically smash red blood cells as they pump.
Wow, the valve literally crushes the cells.
Yeah, it can happen. You also frequently see them in severe inflammatory bowel diseases like Crohn's disease.
Wait, why Crohn's disease? What does inflammation in the gut have to do with breaking down blood?
It's a mechanical failure of that recycling loop we talked about earlier.
The enterohepatic circulation.
Exactly. Crohn's disease often severely inflames the terminal ileum, which is the exact part of the small intestine responsible for reabsorbing those bile acids.
Ah, I see where this is going.
If the gut can't reabsorb bile acids, they are lost in the stool. The liver is now manufacturing bile that is critically low on bile acids, meaning it has a much harder time keeping both cholesterol and bilirubin dissolved.
The whole chemical balance crashes.
It crashes, favoring the precipitation of those black calcium bilirubinate stones.
That is fascinating. It's a domino effect from the end of the intestine all the way back up to the liver.
Everything is connected.
It really is. And that leaves us with the third category, brown stones. So if cholesterol stones are metabolic and black stones are hematologic, what causes a brown stone?
Brown pigmented stones are the hallmark of an infection.
Really?
Yeah. They form in a completely different environment, usually directly within the bile ducts themselves rather than inside the gallbladder. They are composed of a chaotic mixture of calcium bilirubinate, calcium phosphate, fatty acid palmitates, cholesterol, and bacteria.
Wait, bacteria are actually inside the stone?
Yes, physically embedded in it. Brown stones typically form when there is chronic bacterial or parasitic infection in the biliary tree.
Parasites in the bile ducts.
Yep. Certain bacteria, like Escherichia coli, or parasites like liver flukes, produce an enzyme called beta-glucuronidase. This enzyme actively attacks the processed bilirubin in the bile, stripping away the chemical groups the liver added to make it water-soluble.
So it undissolves it.
Exactly.
Huh.
This forces the bilirubin to precipitate out, binding with calcium and bacterial debris to form these soft, earthy, brown stones.
Are they common?
They are much less common in Western countries, but they are highly prevalent in rural parts of East Asia where parasitic liver fluke infections are endemic.
So we have the metabolic yellow cholesterol stones, the blood breakdown black stones, and the infectious brown stones.
That's the trio.
Because the cholesterol stones make up 75% of the cases in the West, let's drill down deeper into how they form. You mentioned the supersaturation and the mucin gel acting as the sticky web.
The sludge.
Right, the sludge. But what absolutely shocked me when reading the clinical review was that this isn't just a passive chemical reaction happening in the dark. Your body actively attacks the process, and in doing so, makes it significantly worse.
Oh, this is the craziest part.
Walk me through the microscopic battle happening in this gallbladder sludge.
This is where the biology gets truly surreal. When those microscopic cholesterol crystals begin to form in the sludge, they are recognized by the body's immune system as foreign, sharp, damaging objects.
Beats it shouldn't be there.
Right. So the immune system dispatches its first responders, macrophages, and neutrophils. These are specialized white blood cells that usually hunt down bacteria.
Okay.
A neutrophil's normal tactic is to physically engulf a pathogen and digest it.
It's basically a microscopic Pac-Man.
That's exactly what it is. But when a neutrophil arrives in the gallbladder and tries to engulf a cholesterol crystal, it encounters a massive problem.
It can't chew it.
The crystal is rock hard, it's sharp, and it's chemically inert. The neutrophil tries to digest it, but it simply can't. The crystal actually physically damages the neutrophil from the inside out.
Oh, wow. It's like swallowing glass.
Exactly. And when a neutrophil is under severe distress and realizes it cannot consume the threat, it initiates a self-destruct sequence.
It blows itself up.
But it doesn't just die quietly. It undergoes a process called netosis.
Netosis. N-E-T-osis. What exactly is a net?
NET stands for neutrophil extracellular trap. The neutrophil literally dissolves its own cellular nucleus, unwinds its own DNA, mixes that DNA with toxic antimicrobial enzymes, and violently erupts.
Wait, what?
It casts its own DNA out like a sticky, highly charged microscopic spider web.
It weaponizes its own genetics. It literally throws its DNA like a net to trap the threat.
Yes. In the context of a bacterial infection, this DNA net is brilliant. It physically traps the bacteria, preventing them from spreading, while the attached enzymes destroy them.
Right.
But in the gallbladder, the threat is a cholesterol crystal. You cannot kill a rock.
Oh, no. So what happens to this DNA net floating in the bile?
Well, DNA is a highly charged molecule. It acts like a powerful biological magnet. It casts out into the bile and immediately begins attracting more and more cholesterol crystals.
They stick to it.
The crystals stick to the DNA web. Then, more neutrophils arrive. See the mass, try to eat the growing mass, fail, and explode, adding more sticky DNA to the web.
It's a vicious cycle.
The immune system's desperate attempt to clear the crystals literally forms the physical scaffolding that binds the crystals together.
Right.
It rapidly accelerates the growth of a microscopic crystal into a solid macroscopic gallstone.
That is deeply unsettling. I mean, your own immune cells, trying to protect you, are essentially acting as the unwitting construction workers building the exact stones that are going to put you in the hospital.
It's a catastrophic biological miscalculation, and it brings up a crucial question.
Which is?
We know the mechanism now. We know the chemistry, the supersaturation, the immune system misfire. But why is the liver suddenly pumping out so much cholesterol that the bile supersaturates in the first place?
Right. If we've evolved to digest food efficiently, what is breaking the recipe so violently?
Yeah.
And that leads us to look outward, away from the microscopic chemistry and toward the macro environment of the patient. Because when you look at the statistics, this isn't a rare, unlucky occurrence. The numbers are staggering.
Oh, they are massive.
In the United States alone, the data shows that approximately 14 million women and 6 million men between the ages of 20 and 74 have gallstones.
The scale of the issue is immense, and prevalence sharply increases with age. Over 25% of women older than 60 are carrying these stones.
1 in 4.
Yeah. When you look at the healthcare burden, in a single recent year, symptomatic gallstones were responsible for 2 million ambulatory care visits and 1 million emergency department visits. It is one of the most common reasons a patient gets admitted to a surgical ward.
Let's focus on that demographic disparity you just mentioned, because it is glaring. 14 million women compared to 6 million men. That is more than double the rate. What is driving that massive difference?
It primarily comes down to endocrinology,
Yeah.
specifically the hormone estrogen. Yes. Estrogen has a profound and complex impact on how the liver manages lipids.
Mm.
At a cellular level, estrogen actively diffuses into the hepatocytes, the main cells of the liver.
Okay.
Once inside, it upregulates the synthesis of cholesterol. It essentially tells the liver to manufacture more cholesterol and to secrete a higher concentration of that cholesterol directly into the bile.
So it's actively turning up the dial on the cholesterol output.
Exactly. But it also does something else. At the exact same time it's increasing cholesterol, estrogen actually downregulates the enzymatic pathways responsible for creating bile acids.
Wait, so it does both?
Yes. So you have a dual effect,
Mhm.
more cholesterol entering the bile and fewer detergent bile acids available to dissolve it. The supersaturation threshold is breached much more easily.
Does this explain why pregnancy is often associated with gallbladder issues? I know a lot of women who had to get their gallbladder out right after having a baby.
Absolutely. During pregnancy, estrogen levels skyrocket, massively increasing the cholesterol saturation of the bile. Furthermore, the body is also flooded with progesterone during pregnancy.
And what does progesterone do?
Progesterone's primary job is to relax smooth muscle tissue to prevent premature uterine contractions. But the gallbladder is also just a sack of smooth muscle.
Oh. So the progesterone relaxes the gallbladder too?
Yes. It causes profound gallbladder paresis, or hypomotility. The gallbladder becomes sluggish. It doesn't empty fully or forcefully when the woman eats.
It's just too relaxed to squeeze.
Right. So you have highly supersaturated, cholesterol-heavy bile sitting stagnant in a relaxed gallbladder that isn't emptying. It is the absolute perfect storm for sludge formation and rapid stone crystallization.
That makes total sense.
This is why women of reproductive age, particularly those who have had multiple pregnancies or women taking estrogen-containing oral contraceptives or hormone replacement therapy, face a significantly elevated risk.
It's a fascinating, if unfortunate, biological side effect of reproduction. But beyond gender, there are massive genetic disparities as well. The clinical data notes that up to 70% of certain indigenous American populations develop gallstones.
70%.
Why such an incredibly high prevalence in a specific ethnic group?
This points to deeply ingrained genetic traits regarding hepatic secretion. Studies on these populations reveal a genetic predisposition to secrete highly lithogenic bile.
Lithogenic meaning stone forming.
Exactly. Their livers natively secrete higher concentrations of cholesterol and lower levels of bile salts compared to other populations. When you take this underlying ancient genetic predisposition and you expose it to a modern, highly processed Western diet, the metabolic pathways are completely overwhelmed.
And that modern diet brings us to perhaps the most pervasive and controllable risk factor, metabolic syndrome. We hear the term metabolic syndrome constantly in relation to heart disease and diabetes. How does insulin resistance, the core of metabolic syndrome, reach all the way into the gallbladder to cause stones?
To understand this, we have to look at how the modern diet alters the fundamental processing architecture of the liver. When a person consumes a diet highly rich in saturated fats and refined sugars, particularly fructose, the body's metabolic pathways adapt in destructive ways.
Why single out fructose? Is it worse than other sugars?
In this context, yes, because fructose is metabolized almost exclusively by the liver, and it bypasses some of the normal regulatory checkpoints that glucose goes through.
So it's a direct hit to the liver.
Exactly. When a massive load of fructose hits the liver converts it directly into building blocks for fat. This drives a process called de novo lipogenesis, literally, the creation of new fat. The liver begins synthesizing massive amounts of triglycerides.
Fat essentially accumulating inside the liver cells.
Yes, leading to hepatic steatosis, or fatty liver. And as this fat accumulates, the liver cells become resistant to the hormone insulin. They stop responding to it normally.
Okay, that's the insulin resistance part.
Now, this state of insulin resistance triggers a specific catastrophic chain reaction for the gallbladder. The resistance actively upregulates an enzyme called HMG-CoA reductase.
HMG-CoA reductase, I recognize that name. That is the exact enzyme that statin drugs target to lower cholesterol, right?
Precisely. It is the master control valve for cholesterol production in the body. Because of the insulin resistance, this enzyme is stuck in the on position. The liver is churning out vast quantities of cholesterol and dumping it straight into the biliary system.
It's just a constant flood.
And simultaneously, The high levels of circulating triglycerides actively decrease the gallbladder's sensitivity to a hormone called cholecystokinin, or CCK.
CCK, what does CCK do?
CCK is the chemical messenger that tells the gallbladder to squeeze. When you eat fat, your intestine releases CCK. It travels in the blood to the gallbladder and tells the muscle to contract and push the bile out.
Oh, I see.
But in a state of insulin resistance and high triglycerides, the gallbladder goes deaf to this signal.
So we are back to stagnation. The liver is pumping out highly saturated, rock-building bile, and the gallbladder is too deaf to the hormonal signals to squeeze it out. It just sits there and crystallizes.
That's exactly the mechanism.
Now, this logic holds up perfectly when we talk about obesity and poor diet. But this is where the medical literature throws a massive curveball. The clinical review highlights something called the bariatric paradox.
Yes. It is one of the most counterintuitive phenomena in gastrointestinal medicine.
Right, because we know obesity causes gallstones. We know insulin resistance causes gallstones. So logic dictates that if a patient undergoes bariatric surgery, say a Roux-en-Y gastric bypass, which results in massive weight loss and functionally cures their type 2 diabetes and insulin resistance almost overnight,
Their risk should drop.
logic says their gallstone risk should plummet, but the data says the exact opposite. Bariatric surgery actively causes gallstones. How is that possible?
To understand the paradox, you have to look at both the physical plumbing changes of the surgery and the metabolic chaos of rapid weight loss. Let's look at the plumbing first. In a Roux-en-Y bypass, the surgeon completely reroutes the digestive tract. The stomach is reduced to a tiny pouch, and the small intestine is cut and reattached so that food completely bypasses the duodenum, the very first section of the small intestine.
Okay, so the food skips a section of the piping. Why does that matter to the gallbladder?
Because the duodenum is the primary sensory organ for dietary fat. That is exactly where the cells that manufacture CCK live.
Oh.
Yeah. When food bypasses the duodenum, the CCK hormonal signal is massively blunted. The gallbladder simply doesn't get the message that food has entered the system. Researchers analyzing post-bariatric physiology have found that the gallbladder's ejection fraction, the percentage of bile it can squeeze out, plummets.
So the surgery physically breaks the communication line to the gallbladder.
Exactly. You induce profound chronic stagnation. The bile just sits there for weeks.
That's the plumbing side. What about the metabolic side?
Combine that stagnation with the metabolic reality of rapid weight loss. When a patient loses 50 or 100 pounds rapidly, they are mobilizing massive amounts of stored fat.
Melting it away.
Right. That fat is broken down, and the cholesterol stored within that adipose tissue is dumped into the bloodstream. The liver takes up this massive influx of cholesterol and has no choice but to excrete it into the bile.
Oh, wow. So you have a gallbladder that has lost its ability to squeeze, suddenly being flooded with an unprecedented tsunami of cholesterol mobilized from the melting body fat.
It is the ultimate recipe for supersaturation and crystallization. In fact, up to a third of bariatric surgery, patients will develop gallstones within the first 12 to 18 months post-op.
A third.
Yes, they often require a second surgery to remove the gallbladder. It is a known and heavily managed risk in bariatric medicine.
That perfectly illustrates how delicate the communication in the digestive tract is. Now, if you want to talk about breaking the digestive tract, let's look at another risk factor highlighted in the review. And this one feels incredibly modern and, frankly, a bit dystopian.
I know exactly what you're going to say.
We are talking about environmental toxins, specifically PFAS.
Polyfluoroalkyl substances, the forever chemicals.
We hear about these in the news constantly regarding water contamination and non-stick pans. But how on earth does a chemical from a non-stick frying pan end up causing rocks to form in my gallbladder?
It traces back to the molecular structure of PFAS. These are synthetic chemicals defined by incredibly strong carbon-fluorine bonds. These bonds are so stable that they essentially do not degrade in nature, hence the name forever chemicals.
And we just consume them.
We ingest them through contaminated water, food packaging, and consumer products. Once inside the body, because of their unique chemical structure, they actually mimic certain types of fatty acids.
So the body confuses the industrial chemical for a nutrient.
Yes. The liver, seeing what it thinks is a lipid, readily takes up the PFAS molecules from the blood. And because the liver cannot break them down, it tries to excrete them the only way it knows how. It pumps them directly into the bile.
So the forever chemicals are dumped into the gallbladder.
But remember that recycling loop we talked about, the enterohepatic circulation?
Oh no, the 95% recycling loop.
Exactly. The bile goes into the gut, does its job, and the body reabsorbs 95% of it to send back to the liver. The PFAS molecules get caught in this exact trap.
They just go round and round.
They're reabsorbed by the intestine, sent back to the liver, and pumped back into the bile. They endlessly cycle and concentrate within the biliary system.
That is terrifying. What do they actually do once they are concentrated in the bile?
They are biologically active disruptors. Research shows that once concentrated in the hepatocytes in the bile, PFAS actively interfere with lipid metabolism. They alter the expression of genes responsible for handling cholesterol and bile acids.
So they're changing our genetics.
They're changing the expression, yeah. They physically disrupt hepatocyte function, pushing the bile composition heavily toward cholesterol supersaturation. Furthermore, endocrine studies show that PFAS can disrupt the regulation of androgens and estrogens, circling right back to the hormonal risks we discussed earlier.
Wow.
They artificially tilt the entire metabolic environment
Yeah.
towards stone formation.
So our industrial environment is literally concentrating inside our gallbladders. It is an amazing example of unintended biological consequences. And speaking of unintended consequences, let's talk about the organisms living inside us.
The microbiome.
Right, we hear constantly about the microbiome and gut health, eating yogurt, taking probiotics. But the clinical review explicitly connects certain bacteria to gallstones. How do bacteria in the large intestine reach all the way up into the gallbladder to cause a cholesterol stone?
Usually the biliary tract is completely sterile. The constant flow of highly alkaline bile acts as a flushing mechanism that prevents bacteria from ascending. But if there is any sluggishness in the flow, any of that hypomotility we've discussed, bacteria from the duodenum can actually migrate upstream.
They swim against the current.
They travel backward through the sphincter of Oddi, which is the muscular valve where the bile duct meets the intestine, and ascends straight into the gallbladder.
And once they get in there, what do?
Certain specific families of bacteria thrive in that environment. The clinical review specifically highlights gram-positive anaerobes. When researchers perform 16S RNA gene sequencing on the bile of gallstone patients, they find completely different bacterial populations compared to healthy individuals.
Like a different ecosystem.
Exactly. These specific infiltrating bacteria possess enzymes that aggressively modify primary bile acids, converting them into a specific secondary bile acid called deoxylate.
Why is deoxycholate bad?
Because high concentrations of deoxycholate are highly lithogenic. It actively promotes the hypersecretion of cholesterol by the liver, and it accelerates the cryptolization process. But it's not just their chemical output, it's their physical behavior.
What do you mean by physical behavior?
Bacteria don't just float freely. To survive in a harsh environment, they build fortresses. They secrete extracellular polymeric substances, basically a dense, sticky, microscopic slime. This forms a biofilm on the wall of the gallbladder.
A bacterial biofilm.
Yes. And researchers conducting in vitro studies have made a stunning discovery. When they place these specific biofilm-producing bacteria into a synthetic bile environment, the rate of gallstone nucleation explodes.
The slime is doing it.
The bacterial slime physically acts as the perfect scaffolding. It provides thousands of microscopic anchor points for the supersaturated cholesterol to latch onto. The bacteria are literally building the foundation for the stones.
So between the shedding DNA nets of our immune cells and the sticky biofilm of invading bacteria, the cholesterol doesn't stand a chance. It's almost guaranteed to crystallize.
It's an uphill battle for sure.
Now, I want to pivot to one of the most bizarre risk factors mentioned in the entire review. We've talked about diet, hormones, surgery, and bacteria. But the review explicitly states that altitude, just simply existing at a high elevation, increases your risk of gallstone.
It sounds made up, doesn't it?
It really does. How on earth does breathing thin air change the chemistry of your bile?
It is a phenomenal demonstration of how interconnected the body's systems are. It all comes down to oxygen. At high altitudes, the barometric pressure is lower, meaning there is less oxygen in the air you breathe. Your entire body experiences systemic hypoxia, a lower concentration of oxygen in the blood.
Which is why people get altitude sickness.
Exactly. Now, the liver is an incredibly oxygen-hungry organ. It requires a massive blood supply to run its chemical factories. When the liver cells experience this chronic, low-level hypoxia, they panic.
They freak out.
They do. They induce the expression of a specific protein called hypoxia-inducible factor 1 alpha, or HIF-1 alpha.
What is HIF-1 alpha?
It is a transcription factor.
Yeah.
It enters the nucleus of the liver cells and actually alters which genes are turned on and off to help the cells survive the lack of oxygen. But one of the side effects of this genetic reprogramming is the massive upregulation of an enzyme called TMAO, or trimethylamine N-oxide.
And what does TMAO have to do with gallstones?
TMAO is a monoxygenase that directly interferes with cholesterol metabolism. High levels of TMAO alter the function of specific cholesterol transporters in the liver, specifically the ABCG5 and ABCG8 transporters, causing them to pump an excessive, unregulated amount of cholesterol directly into the bile ducts.
Unbelievable.
So the simple act of living in a hypoxic environment genetically rewires your liver to hypersecrete cholesterol, driving supersaturation.
That is genuinely incredible. Just the physical altitude changes the genetic expression of your liver.
It's amazing biology.
Now, I have to challenge one specific piece of advice that often gets thrown around, and it relates directly to what we were talking about with the bariatric paradox. We are constantly told that a healthy diet rich in fiber prevents gallstones. And that makes sense. Fiber binds to cholesterol in the gut, helping excrete it.
Right. Fiber is generally protective.
But the clinical review is very explicit that fasting and extreme low-calorie diets are major triggers for gallstone formation. Right now, intermittent fasting is one of the biggest health trends in the world. People are going 16, 18, even 24 hours without eating. Are they actively giving themselves gallstones?
If you look at the fundamental mechanics we've been discussing, the answer is a profound yes. The risk is significantly elevated. It all comes back to the core concept of stagnation.
Because if you aren't eating, you aren't releasing CCK.
Precisely. If you consume 0 calories, particularly 0 fats, your duodenum never triggers the release of cholecystokinin. Your gallbladder receives no instructions to contract. It just sits there completely relaxed, full of bile.
Okay, so it sits there. Is that so bad?
Well, remember the anatomy of the gallbladder. The wall of the gallbladder is highly absorptive. Its normal job is to absorb water out of the bile to concentrate it, making it a stronger detergent.
It's reducing the liquid to make a concentrate.
Yes. But if the bile sits there for 18 or 24 hours without moving, the gallbladder just keeps absorbing water. It keeps concentrating the bile. The cholesterol concentration skyrockets.
Oh, I see.
The liquid evaporates out, leaving this dense, supersaturated, highly lithogenic syrup. The crystals have all the time in the world to nucleate in the mucin gel. Prolonged fasting guarantees gallbladder hypomotility and intense bile concentration. It is the perfect recipe for stone formation.
So while fasting might have other metabolic benefits, as far as the biliary system is concerned, you are essentially daring it to form a rock.
Exactly. The biliary system evolved for regular mechanical flushing. When you remove that stimulus, the chemistry fails.
Okay, so we have built a complete picture of the internal environment. We have supersaturated cholesterol, estrogen influences, dropping CCK levels, bacterial biofilms, and shedding immune cells, all brewing in the dark. But here's the most surprising clinical fact. Despite all of this microscopic chaos, for the vast majority of people, this is a completely silent process.
And silent is the operative word. The clinical data is very clear. The vast majority of people walking around with gallstones have absolutely no idea they're there. They are entirely asymptomatic.
Really?
Yeah. The review notes that if you diagnose a patient with asymptomatic gallstones today, there was only a 10% chance they will develop any symptoms within the next 5 years. Even looking out 20 years, only 20% will ever feel a thing.
So you could literally have a pocket full of stones just hanging out in your abdomen for decades and you'd be none the wiser.
Absolutely.
But when they do decide to make themselves known, when the silence breaks, what exactly is happening mechanically to cause that sudden agonizing pain we described at the beginning of the deep dive?
The hallmark symptom is known as biliary colic, and the mechanism is purely mechanical obstruction. The gallbladder itself doesn't actually have highly sensitive pain receptors on the inside of its lining. The stones can roll around inside the main body, the fundus, all day long without causing pain.
So what triggers the attack?
The attack happens when a stone migrates out of the main body and gets physically wedged into the exit pipe, the narrow tube called the cystic duct.
It gets stuck.
Right. Imagine the patient eats a greasy cheeseburger. The fat hits the duodenum, CCK is released, and the gallbladder forcefully contracts to squeeze the bile out. But there is a rock blocking the exit.
The muscle is squeezing against a blocked pipe?
Yes. The gallbladder is a muscular sac. It tries to overcome the obstruction by squeezing harder and harder. The pressure inside the organ skyrockets. The wall becomes intensely distended. This rapid distension of the wall stretches the visceral nerve
And
fibers.
that stretch is what the brain interprets as pain.
Exactly. And because visceral pain fibers are not mapped cleanly in the brain like the nerves in your fingertips, the pain is usually poorly localized at first. The patient feels a deep, crampy visceral pressure right in the epigastrium, the upper center of the abdomen, right below the sternum.
Which is why they think it's indigestion.
Yes. It usually builds steadily over 15 to 30 minutes until it becomes a severe, constant ache.
Now, earlier we mentioned that the pain often radiates to the right shoulder blade. If the gallbladder is in the front of your abdomen, under your liver, why does your back hurt?
It is a classic neurological phenomena called referred pain. As the gallbladder becomes inflamed and distended, that inflammation can irritate the diaphragm, the large breathing muscle resting right above the liver.
Okay.
The diaphragm is innervated by the phrenic nerve.
The phrenic nerve.
Yes, and the phrenic nerve enters the spinal cord at the cervical levels, C3, C4, and C5. Coincidentally, the sensory nerves that innervate the skin over your right shoulder and scapula also enter the spinal cord at those exact same levels.
Oh, I see.
When the brain receives intense pain signals from the phrenic nerve, it gets confused. It misinterprets the origin of the signal and tells your consciousness that your shoulder is hurting. In physical exams, this is sometimes referred to as the Boas sign hyperesthesia, or pain, right below the right scapula.
The brain is basically crossing its wires. Now, you call this biliary colic, and colic usually implies a pain that comes and goes. Why does the pain stop if the stone is stuck?
Because eventually, the gallbladder tires out. The CCK hormone degrades, the muscle relaxes, the intense pressure drops, and the stone often falls backward out of the narrow cystic duct and back into the wider body of the gallbladder.
It just rolls back in.
Right. The pipe is unblocked, the fluid drains, and the pain completely resolves, usually within a few hours. This is an uncomplicated biliary colic attack.
It's a temporary mechanical jam. I like to visualize the biliary system as a traffic network. If the gallstone is just sitting in the main body of the gallbladder, it's like a car parked in a driveway. It takes up space, but it's not in the way. You don't know it's there.
That is a very accurate way to visualize it.
But when you eat, that car tries to leave and gets stuck on the narrow on-ramp, the cystic duct. So the driveway backs up. The horn is honking. The pressure builds. That's the biliary colic. But when the car backs up into the driveway, the traffic clears. But what happens if the car doesn't back up? What happens if that stone gets permanently wedged in the on-ramp?
This is where we cross a critical clinical threshold. We move from a temporary mechanical problem to a severe inflammatory crisis. If that stone remains impacted in the cystic duct for more than a few hours, the trapped bile inside the gallbladder begins to act as a chemical irritant.
The bile turns on itself.
The mucosa of the gallbladder becomes damaged.
Because it's marinating in its own highly concentrated detergent.
Exactly. The damaged cells release massive amounts of inflammatory mediators, prostaglandins, interleukins, and tumor necrosis factor. The wall of the gallbladder swells immensely, becoming edematous.
It puffs up.
This swelling compresses the small blood vessels supplying the wall, leading to ischemia, a lack of oxygen to the tissue. This condition is no longer biliary colic. It is acute cholecystitis.
How does the patient's experience change when they transition from colic to cholecystitis?
The pain changes fundamentally. It stops being a diffuse, crampy central ache and localizes sharply to the right upper quadrant. The inflammation reaches the parietal peritoneum, the sensitive lining of the abdominal cavity.
So it's much more localized.
Now, any movement, even taking a deep breath, causes exquisite, sharp pain. The patient will likely become febrile, running a fever due to the systemic release of those cytokines. And their white blood cell count will spike as the immune system realizes the organ is under attack.
So the blocked on-ramp has now caused the driveway to catch fire, but that is still technically isolated to the gallbladder. What if the stone makes it past the on-ramp? What if it shoots out at the cystic duct and gets lodged in the main highway, the common bile duct?
That is a multi-car pileup that creates systemic, life-threatening chaos. The common bile duct is the primary highway that drains not only the gallbladder, but the entire liver. If a stone lodges there, a condition called cholelithiasis, it backs up the entire hepatic system.
The liver's drainage is completely blocked.
Yes. And because the liver continuously produces bile, the pressure inside the liver's microscopic canaliculi builds until they actually rupture. The bile specifically, the bilirubin, spills backward into the bloodstream. This rapid accumulation of bilirubin in the blood causes profound clinical jaundice. The patient's skin and the whites of their eyes turn visibly yellow. Their urine turns the color of dark tea because the kidneys are trying to filter the excess bilirubin, and their stool turns pale or clay-colored because no pigment is reaching the intestines.
It sounds incredibly dangerous, but there's another organ attached to that highway, right? The pancreas.
And that is the most feared complication. In most humans, the common bile duct and the main pancreatic duct join together into a common channel just before emptying into the intestine at the ampulla of udder.
Okay.
If a gallstone gets wedged exactly at that exit door, it blocks both ducts simultaneously.
So the pancreatic juices get backed up too.
Even worse, the high-pressure bile can actually reflux backward into the pancreas. The pancreas manufactures incredibly powerful digestive enzymes that are meant to be kept strictly inactive until they reach the gut. The bile forces these enzymes to activate prematurely inside the pancreas.
Inside the organ.
The organ literally begins to digest itself.
Huh.
This is acute gallstone pancreatitis. It causes agonizing, searing, mid-epigastric pain that radiates straight through to the back, intractable vomiting, and massive systemic inflammation. It has a high mortality rate if not immediately resolved.
So a tiny rock, manufactured by accident, can trigger the autodigestion of a vital organ.
It's terrifying.
And it can get worse, can't it? The clinical review mentions a condition with a specific name, ascending cholangitis.
Yes. If the common bile duct is blocked, that stagnant pool of backed-up bile is a perfect culture medium. Bacteria from the intestine rapidly ascend and infect the entire biliary tree. The entire duct system becomes filled with pressurized pus.
Oh, that sounds horrific.
Clinically, doctors recognize this through a diagnostic criteria called the Charcot triad. Severe right upper quadrant pain, high fever with rigors or shaking chills, and visible jaundice.
The triad.
If left untreated for even a short period, the highly pressurized infection ruptures into the hepatic veins, dumping billions of bacteria directly into the bloodstream, causing overwhelming sepsis.
And sepsis is systemic shock.
When it progresses to sepsis, we see the renal pentad. This adds 2 more symptoms to the triad: severe hypotension, a dangerous drop in blood pressure, and altered mental status, like profound confusion or lethargy. At this point, the patient is actively dying, and it is an absolute code red medical emergency.
So we have a clinical spectrum that ranges from entirely silent stones to the painful traffic jam of colic to the flaming driveway of cholecystitis, all the way to the life-threatening multi-car pileup of pancreatitis and cholangitis.
That's the spectrum.
When a patient arrives at the emergency room in the middle of any of these scenarios, doctors need to figure out exactly what is happening under the skin. They need a map. Which brings us to the diagnostic detective work. How does modern medicine track down these tiny stones?
The diagnostic hierarchy is remarkably straightforward, and it relies almost entirely on one specific piece of technology as the first-line MVP, the right upper quadrant ultrasound.
Why ultrasound? I mean, we have MRI machines, we have high-resolution CT scanners. Why rely on sound waves as the first line of defense?
It comes down to the specific physics of ultrasound and the nature of the stones. Ultrasound technology uses a transducer that emits high-frequency sound waves. These sound waves travel through fluid, like the bile in your gallbladder, very easily, showing up as black on the screen.
Okay.
But when these sound waves hit something dense and solid like a crystallized gallstone, they cannot pass through.
They bounce off.
They bounce right back to the probe. The stone shows up as a bright, white, highly echogenic spot. But the real diagnostic power is what happens behind the stone. Because the sound waves couldn't penetrate the rock, they leave a completely dark, empty shadow directly beneath it on the image.
A shadow.
It is called posterior acoustic shadowing. If a radiologist sees a bright white spot with a dark shadow beneath it inside the gallbladder, it is definitive, 100% proof of a gallstone. Ultrasound has over a 90% specificity and sensitivity for gallstones. It can detect stones as small as 2 millimeters.
And it's cheap, fast, and has no radiation. But what about the organ itself? If the patient is in that inflamed, acute cholecystitis phase, can the ultrasound see that?
Absolutely. The technician will look for secondary signs of inflammation. They measure the wall of the gallbladder. A normal wall is paper thin. If the ultrasound shows a wall thickened to greater than 3 millimeters and it looks striated or has a halo of fluid trapped within its layers, that indicates severe edema and cholecystitis.
So the wall itself gives it away.
They also look for pericholecystic fluid, a dark rim of inflammatory fluid leaking out around the outside of the organ.
And there is a physical maneuver they do with the probe itself, right? Their review mentions the Murphy sign.
The sonographic Murphy sign is a brilliant synthesis of imaging and physical exam. The technician finds the exact location of the gallbladder on the screen. They push the transducer probe firmly into the abdomen right over that spot. Then they ask the patient to take a deep, deep breath.
What does breathing do?
When you inhale deeply, your lungs expand downward, flattening your diaphragm. The diaphragm physically pushes the liver and the attacked gallbladder down into the abdomen.
Right into the probe?
Exactly. If the gallbladder is inflamed, driving it directly into the firm pressure of the ultrasound probe will cause sudden, exquisite pain. The patient will literally gasp and abruptly stop inhaling. That sudden catch-in breath is a positive Murphy sign, and it strongly indicates acute cholecystitis.
Okay, so ultrasound is clearly king. But I have to ask a seemingly obvious question. If I swallow a coin or break a bone, they take an x-ray. These are solid stones. Why wouldn't a standard cheap chest or abdominal x-ray immediately show a gallstone?
You would intuitively think it would, but plain film X-rays are functionally useless for gallstone diagnostics. X-rays rely on tissue density, specifically calcium, to block the radiation and show up white on the film. Bones show up beautifully. But remember the chemistry we discussed. 75% to 80% of these stones are made of pure precipitated cholesterol.
And cholesterol's a fat, it's not a mineral.
Exactly. Cholesterol is entirely radiolucent. The X-rays pass right through it as if it wasn't even there. Only 10% to 15% of gallstones have accumulated enough calcium in their matrix to be radio-opaque and show up on a standard X-ray. So relying on an X-ray will give you a false negative the vast majority of the time.
That makes perfect sense. Now, what if the ultrasound is confusing? Say there are stones, but the wall isn't super thick, yet the patient is still in severe pain. Is there a way to test if the plumbing is actually working rather than just looking at a static picture?
Yes. When the anatomy is ambiguous, we test the physiology. To do that, nuclear medicine uses the HID scan. HID stands for hepatobiliary imidodiacetic acid.
That sounds incredibly complex. How does it work?
It is an elegant test of the biliary pathway. The technician injects a small amount of a radioactive tracer, usually technetium-99 meters, into a vein in your arm. This specific chemical compound is designed to be recognized by the liver hepatocytes.
So the liver thinks it's supposed to be processed into bile.
Exactly. The liver actively pulls the radioactive tracer out of the blood and secretes it directly into the bile ducts. The patient then lies under a gamma camera, which detects the radiation. Over the next hour, the doctor literally watches a glowing time-lapse of the bile moving through the system in real time.
It's like injecting dye into a river system to see where the dam is.
Precisely. If the tracer flows into the liver, down the common bile duct, and into the intestine, but the gallbladder remains completely dark and never fills with the glowing tracer, you have your diagnosis. The cystic duct is 100% obstructed by a stone. The dye simply can't get in.
And what if the dye does get in? Can you test how well it squeezes out?
Yes. If the gallbladder fills, they can then inject an artificial synthetic version of CCK into your IV.
To make it squeeze.
This artificially forces the gallbladder to contract. The camera then measures exactly how much of the glowing bile is squeezed out. This calculates your ejection fraction. If it's below 35%, it diagnoses a condition called biliary dyskinesia. The gallbladder simply doesn't work, even if there are no visible stones.
Okay, so ultrasound and HID scans handle the gallbladder perfectly. But what about that multi-car pileup scenario? If the ultrasound shows that the common bile duct is dilated, implying a stone has escaped and is blocking a main highway, how do doctors map that out?
When a stone escapes into the common bile duct, the diagnostic gold standard shifts to an MRI, specifically an MRCP, or magnetic resonance cholangiopancreatography.
What does the MRI do differently?
MRI uses massive magnetic fields and radio waves to excite the protons in the water molecules inside your body. The MRCP software is specifically tuned to suppress the signal from solid tissues and amplify the signal from static fluids. Because the bile ducts and pancreatic ducts are essentially tubes of slow-moving fluid, they light up brilliantly on the scan.
It creates a perfectly isolated picture of just the fluid.
It generates incredibly detailed, high-resolution, three-dimensional models of the entire biliary tree. The radiologist can rotate the image on a screen and spot exactly where a tiny 3mm stone is wedged in the distal common bile duct. And it's completely non-invasive.
Which brings me to a major question. If MRCP gives you a flawless 3D non-invasive map of the problem, why would the clinical review heavily discuss another procedure called ERCP? ERCP stands for endoscopic retrograde cholangiopancreatography. It involves passing a flexible camera down the patient's throat, through the stomach, and into the duodenum. It requires sedation, and the review notes it carries risks of perforating the bowel or causing massive pancreatitis. Why would any doctor subject a patient to an ERCP if an MRCP exists?
It is the crucial difference between taking a picture of a fire and putting the fire out. MRCP is purely diagnostic. It is a map. If it shows a stone causing ascending cholangitis, the patient is still actively dying from sepsis. ERCP, on the other hand, is both diagnostic and therapeutic. It is a surgical intervention performed through an endoscope.
Walk me through exactly what happens when the scope gets down there. How do they get the stone out?
The gastroenterologist navigates the side-viewing endoscope through the stomach and into the duodenum till they find the ampulla of Bladder, that tiny nipple-like sphincter where the common bile duct empties into the intestine. They extend a microscopic catheter out of the endoscope and thread it backward retrograde up into the bile duct.
They thread a wire up the plumbing backward.
Yes. They inject contrast dye under live X-ray fluoroscopy to visually confirm the stone's exact location. Once confirmed, they perform a sphincterotomy. Using a tiny electrically heated wire, they literally burn and cut the sphincter muscle, widening the exit door permanently.
They demolish the blocked toll booth.
Exactly. Then they slide a tiny deflated balloon or a wire basket past the stone, inflate the balloon, and physically drag the stone down the duct and pull it out into the intestine.
They clear the multi-car pilot from the inside without ever making an incision on the patient's skin.
They instantly decompress the system, reverse the jaundice, and stop the sepsis. It is one of the most powerful life-saving procedures in gastroenterology. And to ensure that ERCP and surgery are used appropriately, the clinical review heavily references international protocols, specifically the 2021 Japanese Society of Gastroenterology guidelines.
Why specifically the Japanese guidelines?
Because they developed an incredibly rigorous algorithmic approach known as the Tokyo Guidelines. These guidelines take the guesswork out of diagnosis. They categorize patients using hard data points: fever, white blood cell count, C-reactive protein levels, and specific ultrasound findings like wall thickness. The algorithm objectively categorizes the cholecystitis as mild, moderate, or severe and dictates exactly when to give antibiotics, when to do an ERCP, and crucially, exactly when to move to surgery.
Which bridges the gap perfectly to the final phase of this medical journey, treatment. We have mapped the stones, we've cleared the immediate blockages with ERCP, but the defective factory, the gallbladder itself, is still sitting there. How do we get rid of it? Going under the knife versus medical management.
And when we talk about going under the knife, we are talking about a staggering volume of surgical intervention. The clinical review states there are over 1 million cholecystectomies, surgical removals of the gallbladder, performed annually in the United States alone.
1 million organs permanently removed every single year. Let's detail the absolute gold standard for this procedure. How is a modern cholecystectomy actually performed?
The vast majority of these are performed via laparoscopic cholecystectomy. Prior to the late 1980s, removing a gallbladder required a massive open incision across the abdomen, cutting through layers of muscle, resulting in a week-long hospital stay and intense pain. Laparoscopy revolutionized this.
What does the surgeon actually do?
The patient is under general anesthesia. The surgeon makes 3 or 4 tiny incisions, usually less than an inch long, in the abdomen. Through the first incision at the belly button, they pump carbon dioxide gas into the abdominal cavity.
Why carbon dioxide?
Because it inflates the abdomen like a balloon, creating a large, open, physical working space inside the body. Furthermore, carbon dioxide is highly soluble in blood, meaning if a bubble accidentally enters a vein, it dissolves instantly, preventing a fatal gas embolism.
That is a very smart biological safeguard.
Once the abdomen is inflated, they insert a high-definition laparoscope, a camera, through the belly button. Through the other tiny incisions, they insert long, thin instruments. The surgeon visualizes the gallbladder on large monitors.
And how do they safely detach an organ that's glued to the liver and connected to vital bile ducts?
This is the most critical and delicate part of the operation. The surgeon must establish what is universally known as the critical view of safety. They carefully dissect away the fat and fibrous tissue in an area called Cowlett's triangle. They must unequivocally identify 2 specific tubular structures: the cystic duct, the exit pipe, and the cystic artery, the blood supply.
They have to be absolutely certain they aren't looking at the main common bile duct.
Exactly. Accidentally cutting the common bile duct is a catastrophic surgical complication. Once the cystic duct and artery are flawlessly isolated, the surgeon places titanium or polymer clips across both of them, sealing them permanently. Then, they use surgical scissors to cut between the clips.
The organ is disconnected from the plumbing and the blood supply.
Then, using an electrocautery device, essentially a heated spatula, They carefully peel the gallbladder off the underside of the liver, burning the tissue to stop any bleeding. Finally, they drop the entire organ, full of stones, into a small plastic specimen bag inside the abdomen and physically pull the bag out through the incision at the belly button.
The gas is deflated, a few stitches, and you're done.
In many cases, it is an outpatient procedure. The patient goes home the very same day.
It is remarkably elegant. Now, you mentioned the fear of stones being in the common bile duct. If the surgeon is in there and they suspect a stone escaped before they clip the duct, what do? Do they just leave it and do an ERCP later?
They could do an ERCP later, but often they will address it intraoperatively. First, they perform an intraoperative cholangiogram. They insert a tiny catheter into the cystic duct, inject dye, and take a live X-ray on the operating table to prove there are no stones in the main highway.
And if they see a stone on the X-ray?
The surgeon can perform a common bile duct exploration. Using incredibly fine instruments, they can pass a tiny camera, a cholelithiasis, directly into the duct system, locate the stone, and extract it using a wire basket.
But opening the main bile duct must carry risks.
It does. Anytime you cut the common bile duct, there is a risk of stricture scar tissue forming as it heals, which would permanently narrow the duct and recreate the traffic jam. To prevent this, if they have to make a large incision on the duct, they might place a T-tube. It's a rubber tube shaped like a T that sits inside the duct, splitting it open while it heals, with the long end protruding through the patient's skin to drain bile into a bag for a few weeks until the duct heals securely around it.
Okay, so the surgical approach is incredibly refined, but I have to ask the question that every single patient asks when told they need surgery. Doc, isn't there a pill I can take? Can't you just blast them with a laser? What does the clinical literature say about non-operative management? The review mentioned the Chenoy study and the SECURE trial.
The clinical data is heavily weighted against non-operative approaches. The Chenoy et al. Study was a massive review covering data from 2000 to 2020. They specifically looked at patients who opted for lithotripsy extracorporeal shockwave therapy versus surgical removal.
Lithotripsy is where they use high-energy sound waves to physically shatter the stones inside the body, right? It's used for kidney stones all the time. Why not gallstones?
It worked for kidney stones because the fragments can easily pass down the ureter. But for gallstones, the Chenoy study found it is vastly inferior to surgery. First, the shockwaves cause significant tissue trauma to the liver and surrounding organs, requiring heavy pain management. Second, when you shatter a gallstone, you create hundreds of tiny fragments,
which are now perfectly sized to get wedged in the cystic duct and cause a massive attack.
Exactly. You increase the immediate risk of severe biliary colic and pancreatitis. The SECURE trial corroborated this. They looked at restrictive strategies, trying to delay or avoid surgery in symptomatic patients through medical management or dietary changes. The conclusion was that these strategies failed to significantly reduce pain episodes, and overwhelmingly, the patients eventually required the surgery anyway, often under more complicated emergency circumstances.
What about medications? The review explicitly mentions a drug called ursodiol.
Ursodiol is an oral bile acid. The theory is that if you take enough of this pill, it will alter the bile acid pool in your liver, increasing the detergent concentration enough to slowly chemically dissolve the cholesterol stones over months or years.
Does it work?
Very poorly. The clinical dissolution rate is under 50%. It only works on small, pure, non-calcified cholesterol stones in a gallbladder that still functions perfectly. And here is the fatal flaw. Even if the ursodiol successfully melts the stones after 2 years of taking the pill, the moment you stop taking the medication, the underlying metabolic environment returns and the stones immediately reform.
I think an analogy is essential here to understand why surgery is the gold standard. As we discussed earlier, the gallbladder is a factory. It is designed to store and concentrate bile. But due to hormones, diet, and genetics, it has become a defective factory. Its machinery is broken, and it is now manufacturing rocks.
Correct.
Using lithotripsy to shatter the rocks or taking ursodiol to slowly melt them is the equivalent of aggressively sweeping up the dust on the floor of the malfunctioning factory. You might clear the floor for a day or a month, but the factory itself is still fundamentally broken. If you do not shut the factory down, if you don't surgically remove the gallbladder, it will inevitably just manufacture more stones tomorrow.
That is the exact biological reality. You have to eliminate the source of the pathogenesis. Now, while a laparoscopic cholecystectomy is a routine, definitive, and highly safe cure, we must examine the dark side of this disease. What happens when patients refuse surgery or when the disease goes unrecognized for years? What happens when these stones are left completely unchecked to wage war inside the abdomen?
Which brings us to the complications and surgical prognosis. The clinical review details a few incredibly rare but frankly terrifying anatomical anomalies that arise from long-term, untreated gallstone disease. Let's start with Merici syndrome.
Merici syndrome is a severe anatomical distortion caused by chronic inflammation and a very specific stone placement. Imagine a very large gallstone, perhaps the size of a walnut, gets wedged firmly into the neck of the gallbladder or the cystic duct.
So it's blocking the on-ramp.
Yes. But because of its massive size, it doesn't just block its own exit. It bulges outward so far that it physically presses against the common bile duct running adjacent to it. It causes an extrinsic compression.
So it's a stone inside the gallbladder that is physically crushing the main highway from the outside.
Exactly. It causes all the symptoms of a blocked common bile duct, severe jaundice, liver backup, without the stone actually being inside the duct. The chronic inflammation glues the gallbladder, the stone, and the common bile duct together into a dense fibrotic mass. This makes surgery incredibly perilous because the surgeon can no longer visually distinguish the anatomy. The critical view of safety is obliterated.
That sounds like a surgical nightmare. But as complex as Merici syndrome is, the review describes something even more bizarre. I read this section and I had to read it twice to believe the biology. Walk us through Bouveret syndrome.
Bouveret syndrome is the extreme endgame of neglected gallstone disease. In this scenario, a massive gallstone, sometimes the size of a chicken egg, sits inside the gallbladder for years, causing severe, smoldering, chronic inflammation. The wall of the gallbladder becomes permanently adhered to the adjacent wall of the duodenum, the small intestine.
The two organs fuse together.
Yes. And over time, the relentless pressure of that massive stone, combined with the inflammatory enzymes, causes ischemic necrosis. The tissue literally rots away. The stone completely erodes through the wall of the gallbladder and simultaneously erodes through the wall of the duodenum.
It burns a tunnel right between the two organs, a fistula.
A cholecystoduodenal fistula. Once the tunnel is large enough, this massive egg-sized rock falls out of the gallbladder and drops directly into the digestive tract.
So the stone is now inside the intestines, mixed with the food.
It begins to travel down the small intestine, propelled by normal digestive contractions. But the small intestine gets narrower as it goes. Eventually, this massive stone reaches a natural bottleneck, usually the ileocecal valve, the sphincter where the small intestine meets the large intestine.
And it gets stuck.
It becomes completely wedged, causing an absolute total mechanical bowel obstruction. This specific event is called a gallstone ileus. It happens in about 0.3% to 0.5% of gallstone patients. The patient experiences agonizing abdominal pain, massive distension, and severe vomiting, as nothing can pass through their digestive tract. It is a massive, highly lethal surgical emergency.
The surgeon has to open the abdomen, cut the bowel open to extract the rock, and then somehow deal with the gaping hole between the gallbladder and the stomach up top. That is a truly worst-case scenario. But let's bring it back to reality for the vast majority of patients heading in for an elective laparoscopic cholecystectomy. What is the actual prognosis? What does the data tell us about the risks of the surgery itself?
The statistical prognosis is overwhelmingly excellent. The mortality rate following a standard elective laparoscopic cholecystectomy is exceptionally low, less than 0.5%. However, surgical researchers are constantly analyzing data to identify which specific patients are at higher risk for complications so they can better prepare.
Right. And you would intuitively assume that massive obesity would be the biggest risk factor. Operating on a patient with a very high BMI seems mechanically much harder.
That was the conventional surgical wisdom for decades. But the review highlights a major paradigm-shifting study by Nassar et al. They analyzed an incredible 4,699 surgeries, spanning nearly 2 decades, to explicitly test this assumption. They compared outcomes between lean patients and morbidly obese patients with a BMI over 35.
What did the data show?
It completely contradicted the assumption. They found absolutely no statistically significant difference in operative times, intraoperative complications, readmission rates, or mortality between the highly obese group and the control group. The modern laparoscopic instruments, combined with the new peritoneum gas inflation, allowed skilled surgeons to navigate the adipose tissue without compromising safety.
If a patient's weight isn't the primary driver of bad surgical outcomes, what is?
That question was answered by another major study cited in the review by Fagenson et al. They demonstrated that the true predictor of morbidity and mortality is not BMI, but rather the patient's physiological frailty.
Frailty, how do you measure that clinically?
They use a validated tool called the Modified Frailty Index. This index evaluates the patient's physiological reserve by looking at their comorbidities. Does the patient have insulin-dependent diabetes? Do they have severe COPD? Do they have a history of congestive heart failure? Are they functionally independent, or do they require assistance with daily tasks?
So it's a measure of how worn down their physiological systems are.
Exactly. A highly frail patient, even if they have a perfectly normal BMI, faces significantly higher risks of postoperative pneumonia, cardiovascular events, and death compared to a heavily obese but physiologically robust patient. The body's ability to withstand the stress of anesthesia and surgical trauma dictates the outcome.
That makes perfect sense. Now, this leads to the ultimate question, and one that is arguably the most common concern for any patient facing this surgery. We just spent a massive amount of time explaining how crucial the gallbladder is. It's the factory that stores and concentrates the detergent required to digest fat. If you surgically remove that vital organ, how does the human body possibly compensate? What does daily life actually look like for you when the gallbladder is gone in the garbage?
The human body's capacity for physiological adaptation is remarkable. When you remove the gallbladder, you haven't stopped the production of bile. The liver continues to manufacture primary bile acids 24 hours a day, exactly as it did before.
But there is nowhere to store it. The reservoir is gone.
Exactly. Without the gallbladder to act as a dam, the bile just continuously, slowly drips down the common bile duct and directly into the duodenum.
So instead of a massive, highly concentrated squirt of bile precisely when you eat a fatty meal, it's a slow, steady, diluted trickle all day and all night.
Yes. And for the vast majority of patients, this continuous slow drip is perfectly sufficient to digest a normal diet. Their enterohepatic circulation adapts to the new rhythm, and they enjoy normal longevity and a quality of life entirely comparable to someone who still has their gallbladder. However, the system has a breaking point.
What happens when they push the system?
Because they no longer possess that stored reserve of highly concentrated bile, if the patient sits down and eats a massively high-fat meal, say a whole pizza or a giant plate of fried food, the sudden influx of fat overwhelms the slow trickle of bile. There simply isn't enough detergent present in the gut at that exact moment to emulsify all that grease.
The fat globules don't break down into micelles.
Right, and unabsorbed fat acts as a powerful osmotic laxative in the large intestine. It draws water into the bowel, leading to a condition called bile acid malabsorption, which manifests as urgent postprandial diarrhea, intense bloating, and cramping. This is sometimes referred to as post-cholecystectomy syndrome.
So the surgery forces a behavioral change.
Yes. Postoperative patients are almost universally advised to permanently transition to a diet lower in saturated fats and to eat smaller, more frequent portions. This allows their continuous, slow drip of bile to keep pace with the digestive demands. The body functions beautifully, but it can no longer handle the extreme dietary spikes.
Pulling all of these clinical, biological, and surgical threads together leaves us with a truly profound realization about how our bodies operate, and more importantly, how they fail to adapt to the reality of the modern world.
It really does. We have traced this incredible microscopic journey from start to finish. We started with the liver performing complex hydroxylation to build amphipathic detergents. We watched how an imbalance in that chemistry creates supersaturated cholesterol that precipitates out of the fluid.
We saw how our own immune system's neutrophils mistakenly attack those crystals, violently shedding their own DNA to build a sticky net, and how invading bacteria construct biofilms that act as the scaffolding to build a microscopic crystal into a macroscopic rock.
We explored how a diet heavy in refined sugars triggers insulin resistance, locking the HMG-CoA reductase enzyme in the on position, flooding the bile with cholesterol, while simultaneously silencing the hormonal signals that tell the gallbladder to empty.
We detailed how those resulting stones can sit silently for decades, or suddenly migrate into the narrow ductwork, triggering the agonizing visceral stretch of biliary colic, or escalating into the life-threatening systemic chaos of acute pancreatitis and septic cholangitis.
And ultimately, we saw how the incredible technology of ultrasound, MRCP, and the therapeutic intervention of ERCP allow us to map and decompress the biliary tree, paving the way for a laparoscopic cholecystectomy to definitively shut down the broken factory forever.
But as we close out this deep dive, there is one final, provocative concept buried in the clinical data that completely reframes everything we've just discussed. We've talked extensively about how our modern diets and environments trigger this disease. But the clinical review explicitly notes that genetics account for roughly 25% to 30% of the risk for developing gallstones.
It's a massive inherent risk factor that you were simply born with.
Exactly. They specifically point out mutations like a polymorphism in the mucin-like protocadherin gene, the gene responsible for creating that sticky gel that traps the crystals. We evolved these exact genetic traits hundreds of thousands of years ago in an environment where humans experienced prolonged fasting, scarce dietary fats, and massive physical exertion. These genes helped us survive.
And now they're working against us.
Right. And here's the thought I want to leave you with. Right now, we are taking that ancient genetic programming and we are violently colliding it with a completely novel industrialized world. We are flooding our livers with refined fructose. We are actively altering the microbiome in our intestines with highly processed foods, creating bacteria that pump out stone-forming acids. We're literally accumulating indestructible synthetic forever chemicals like PFAS in our biliary systems, chemicals that hijack our lipid metabolism. As these modern, inescapable environmental factors aggressively interact with our ancient genetics, we have to ask a terrifying question. Are gallstones no longer just an unlucky genetic trait or an occasional misstep in your diet? Are they, in fact, becoming an inevitable biological clash? A complete system failure resulting from forcing an ancient digestive system to operate in a heavily toxic industrialized environment. It makes you profoundly rethink the microscopic chemistry happening inside you every single time you sit down to eat. We will see you on the next deep dive.